Well, hi, everyone. Thank you for joining us today. I'm Hannah. I am an obesity medicine fellow at VCU at the Healthy Lifestyle Center here in Richmond, and a new co-chair of our newly formed Food Insecurity Working Group with the AAP. This is the first event that we're putting on, and we're really excited about it. So thanks for joining us at lunchtime. I wanted to introduce our first two speakers because they're going to be going together. But just first, I think we said this in the email that just went out, but if you have any questions throughout the talk, feel free to put them in the chat, and then we'll have a Q&A towards the end where we'll hopefully get to address those questions. So first, I'm going to introduce Megan Butler. She holds a Bachelor of Science degree from the University of Maryland and is currently pursuing a Master's in Public Health degree from George Washington University. In her current role as the Health Equity Director for the Federation of Virginia Food Banks, Megan is strengthening Virginia's food banks' capacity to reduce health disparities and promote nutrition security through leading implementation of a statewide health equity plan. Megan began her career in healthcare as a registered dietitian and certified diabetes care and education specialist, where she practiced trauma-informed nutrition counseling for over 5 years. Megan believes that our culture needs to do more to make health attainable for everyone, and she's committed to facilitating policies, systems, and environments that support all people in achieving their desired level of health. We're really excited to have her joining us today. And I believe she'll be speaking also with Nicole Salinas. I'm going to go ahead and introduce her as well, and then you guys are welcome to screen share and get started. But Nicole is the Nutrition Benefits Access Coordinator for the Federation of Virginia Food Banks. In this role, she enhances public awareness of federal nutrition programs to increase access and participation in the Commonwealth. Previously, she served as the Food Safety and Quality Manager at Greenswell Growers, a local donor of leafy greens. She holds a bachelor's degree in food science and technology from Virginia Tech with a strong background in food and agricultural development. In college, she was active in efforts to address food insecurity in the New River Valley area. She's excited to use her experience and passion for the mission to help more Virginians access the programs that they need to thrive. Thank you for joining us today, and feel free to share whenever you're ready.
Awesome. Hey, everybody. It's great to be here today. Let me make sure this is all working the way it needs to. All right. Good. Can you see the screen all right? Great. Well, as Hannah said, my name is Megan, Health Equity Director at the Federation of Virginia Food Banks. We are a state association that exists to support and build capacity of Virginia's 7 food banks that span the entire state. Nicole and I are especially glad to be here today because of how important this timing is, and we need all partners really mobilized to support your patients, our neighbors, in meeting their food needs. As you all know, it's the end of the SNAP emergency allotments and the end of Medicaid continuous enrollment. And we are seeing already a significant surge in food insecurity across the Commonwealth, as much as 35 to 45% increase in need already. So we're grateful for your partnership in helping connect your patients to the resources that exist and that they are eligible for. As you may know, food insecurity is a widespread and is a significant health equity issue. In Virginia, 1 in 10 children experienced food insecurity in 2020. That's 182,170 children. Food insecurity impacts every single county and congressional district in the Commonwealth, but it disproportionately impacts specific communities, especially Black and Latino communities. Here's a crazy looking chart just displaying how disparately impacted communities of color are by food insecurity. The dark blue and light blue lines, dark blue is median food insecurity rate among Black persons, light blue line is median food insecurity rate among Hispanic persons, the grayish line is median food insecurity rate among white persons. All of this is by county, and this brown line is the median food insecurity rate for the entire county. So you can see that Black and Hispanic persons are pretty consistently higher than the county median for the entire state of Virginia. And likewise, white person food insecurity rates for white persons are consistently lower than the median county rate. So we've got a significant disparity in those who are facing hunger. And when we talk about food insecurity, it's impossible to talk about food insecurity without talking about health. Virginia's food banks are recognizing that we have a role to play in promoting health, and that without doing that, we're just perpetuating a cycle of food insecurity and chronic disease. So pictured here are the root causes of food insecurity: poverty, systemic racism, lack of affordable housing, and high healthcare costs. High healthcare costs are actually the #1 cause of bankruptcy across the country. And high healthcare costs can actually lead to someone to develop food insecurity if they're not connected to the right types of foods, or they go, for long periods of time without getting connected to resources that can help them meet their food needs. This can actually further worsen health outcomes and just lead to a perpetual cycle of food insecurity and chronic disease. So we're really grateful to be deepening our partnerships with the health sector. I'll talk a little bit about how we can deepen our work together today. But just first, a little bit more context building. I want to share about just how costly food insecurity is. I'll be talking about adults right now, but we know that food feeds an entire household, right? So, and there's usually one budget for the entire household. So that's just the framing here. But food insecurity increases the risk of chronic diseases for adults like diabetes, hypertension, heart disease, and depression. In fact, people facing food insecurity are 2 times more likely to develop diabetes in their lifetime, leading to an increased healthcare cost annually in Virginia of about $1,500, almost $1,600 per person, leading to around $1 billion in excess healthcare costs in Virginia. Again, I mentioned food insecurity is the #1 cause of bankruptcy. All this together can lead to a perpetual cycle of food insecurity, chronic disease, high healthcare costs, et cetera. And just in the middle here, worth noting is that this is incredibly stressful for households and communities. Want to note quick, the health impacts of food insecurity for children. These include, and these are CDC figures here, poor overall health status, low birth weight, iron deficiency anemia, birth defects, asthma, mental health, and academic challenges. Health happens in the community, and food is healthcare. We're looking at food as a source of health promotion, disease prevention, and really shifting the paradigm and moving upstream, investing resources in promoting nutritious food access to improve health. Just thinking about where people are traditionally connected to services, moving from the historical treatment approach to looking at food and nutritious food as food intervention, or nutrition and health intervention. Who we are a state association of food banks, as I said. Our mission is to facilitate statewide collaboration among Virginia's food banks, partners, and neighbors to improve nutrition security and empower strong, healthy communities. Our vision is a healthier, food secure Virginia. You can see here pictured on the bottom right is a map of all 7 of our food banks and their unique service areas. I'll also provide a link to this for you later to connect to your local food bank and begin to form those relationships. But each of the food banks have their own warehouses, at least one warehouse, if not 2 warehouses, where they store millions of pounds of food at a time to deliver through 1,000 partner agencies that serve every locality in Virginia. Every year, Virginia's pantry network and food banks reach around 800,000 neighbors, and distributed in 2022, we distributed 135 million pounds of food. Just a quick visual on the difference between a food bank and a food pantry. A food bank is a warehouse that collects food from donations, private donations, farms, government commodities, restaurants, retailers, again, storing millions of pounds of food at a time, distributing that to community organizations like faith-based organizations, soup kitchens, schools, other stood-up nonprofit organizations that exist to feed and nourish community members. So those are our pantry network. Again, we have 1,000 pantry partners in Virginia, many of whom are volunteers, though some are staff. So again, another visual of that: donated food and money go to local food banks, then go to food pantries and partners, and nourish our neighbors in need. Virginia's food banks are actually evolving. I don't know if you've been to a food pantry lately, or excuse me, Virginia's pantries are evolving. I don't know if you've been to a food pantry lately. If not, I encourage you to do so. We are actually leading a statewide initiative called the Healthy Pantry Initiative. We are supporting that network of 1,000 pantries in implementing more neighbor-centered and health-focused practices. So you can see here on the left are some images of what some pantries look like these days, more like a farmer's market style pop-up or really grocery store market in some ways. And the bottom left includes a visual of delivery or drive-through opportunities that are now becoming available for, a lower stigma, more an anonymity option of getting food, since there still is a significant stigma for people facing food insecurity. But on the right-hand side are 4 categories of actions that Virginia's food banks are supporting the network of 1,000 pantries in implementing. So our 4 key strategies that we're working with the network to improve our food availability, making sure that foods offered through the pantry network meet the unique dietary needs of neighbors facing hunger, neighbor-centered, removing barriers so neighbors facing hunger can access the foods they need to thrive. So looking at hours of operation, delivery, etc. Health education, making sure that neighbors are empowered with the tools and self-efficacy to make healthy choices. And lastly, community connections. Community partners working in collaboration to connect neighbors with additional resources and supports to help them thrive, like getting connected to SNAP, WIC, and other benefits that they may be eligible for. Virginia's food banks are collectively implementing a health equity state plan. And here are some of the actions that we are doing differently as a result of that commitment together. We are receiving referrals from health providers to connect patients to food assistance and benefits, ranking the nutritional quality of foods provided, and sourcing more culturally relevant foods, again, removing barriers, and leading our network of 1,000 pantry partners to implement more health-focused and neighbor-centered practices so that all Virginians facing hunger can reach their full potential. And here's where you fit in. So here are 4 separate options that you can do to better partner and make these food resources available to the patients that you see every day. I want to start on the top. These are, probably the most, it would require the most involvement from you all. So that's where the pyramid is pointing toward the top, higher involvement, the bottom, more of a hands-off approach. But all are options that you can do. Start today if you're not already doing, or if you're working somewhere lower on the pyramid, you can build your way up. So the top, screen, refer, and offer food on site at the clinic. Partner with your food bank to offer medically tailored food boxes or produce boxes to give out directly to your patients. We know that CMS is going to require all healthcare institutions to be screening and referring by the year, I think it's 2024, with penalties in 2026. So we know that that's kind of the baseline here. We're expecting that no matter what you're doing, you're screening and referring. And Virginia's food banks use Unite Us as a tool to receive referrals from healthcare directly. Below that, again, maybe one level up on the level of involvement, screen, refer, and assist your patients today in finding their nearest food pantry and or enrolling in SNAP. So you can still refer them to, get connected or provide that additional warmer handoff, but you can also sit down and work with them to say, what's your zip code? Let me go on the Federation's website and find the nearest pantries to you so I can help you get connected to these pantries now. And you can train your staff, Nicole will talk about this, but you can train your staff on how to enroll that patient today in SNAP. The level below that is just screen, and if they screen positive, refer them to the local food bank using Unite Us. That warm handoff, making sure that that patient is connected and someone will follow up with them. And then as a baseline, screen and provide information to the patient via, sorry, that's a typo, that should say handouts or posters on where they can find their nearest pantry. So I want to skip ahead and just show you our food assistance page. Hopefully, are you still seeing my screen here? Yes. Okay, great. So if you go to vafoodbanks.org/find assistance, I'll make sure you have the link. You scroll to the bottom. This is a really great place for you to start in helping your patients find their nearest food pantry. So if you look on the map and say you're in Central Virginia, you'd go over here and click on Feed More, and then scroll down. And here's a place, each food bank has their own place where you type in your zip code and find a list of pantries nearest to you. So here's my current location. And now you can see here, there's an entire list of pantries that come up. So you can print out this list or sit with your patient and show them how to do this on their phone. A lot of the calls we get through hunger hotlines and other contact made by neighbors, we call them, your patients, are just how do I get connected? So really this tool as a resource is something that's so helpful. Going back here. All right, other best practices, this one's kind of related to that. Know your local food and nutrition resources, visit that website to find a list of your nearby pantries. I encourage you, if possible, to go to these pantries, form relationships. That warm handoff can make all the difference, especially for mixed status families or families that may have reservations and saying, well, I didn't expect that I was somebody who would need to go to a pantry. That's for somebody else, not me. If you have that relationship and can work to remove that psychosocial stigma, that can go a long way. And then next is just offering multiple layers of resources for your patients. Not all patients are going to be comfortable sharing that they are food insecure with you. It's just something that's still stigmatized that, is going to take multiple layers of building trust and consistency to really have that conversation sometimes. So layering on, in addition to screening and referring, we provide a poster or a handout can be really helpful. And lastly, I think what's so exciting about this work is just the true win-win-win. It's a win for our neighbors, it's a win for health providers, it's a win for food banks to invest resources and energy upstream in screening for social determinants and connecting people that screen positive to food when they screen positive for food insecurity. For our neighbors, we know that it decreases stress and improves mental well-being. It improves employability and economic outcomes. It improves their access to healthy and culturally relevant food to improve their health, lowers their out-of-pocket costs, and can result in a reduction of those food access barriers that they face. For health providers, improved HEDIS or other value-based measures, decrease hospital admissions and readmissions, improved care quality and especially continuity, decrease length of stay by addressing social determinants of health early in that hospital journey. So if you're actually screening for social determinants while a patient is still in the ER, there's good data to support that that's actually going to result in as much as a 1-day decrease in length of stay. For food banks, connecting more patients in need of food resources to the resources they need and removing barriers. We're not reaching everyone. And so this increased partnership, increased collaboration can really help us to move the needle on closing the meal gap. And then additionally, shifting resources upstream really increases the scalability and sustainability of this work, resulting in improved nutrition security and improved health outcomes. So just really briefly, I want to show you how us partnering and connecting, identifying food insecurity early can influence a patient's trajectory. So you have Maria, she's a single mother, one of 2/3 of Americans who are living paycheck to paycheck right now, and she faces an unexpected car payment that leads her to experience food insecurity. She already had prediabetes, but now the stress and the coping mechanisms that she has to engage in actually push her over to the edge to develop diabetes. She's also put on expensive medications, has a hard time managing her blood sugar, leading to sickness, days off of work, further decreasing her household income and increasing her food insecurity. So on this journey, we see food pantry coming in, already after she's had to incur that high medical bill. And we're proposing that we need to move upstream, really screen for food insecurity status earlier before she's diagnosed with diabetes and make sure that she's connected to resources that she needs through this partnership. So that's all I have, and I'm going to turn it over to Nicole to take us through the SNAP work.
Thanks, Megan. Hello, everybody. I'm Nicole Salinas, and I'm going to be going over the Supplemental Nutrition Assistance Program, or as some of you may know it as SNAP. So SNAP is a food nutrition assistance program that provides low-income individuals with monthly funds to purchase healthy groceries. And this is through an electronic benefits transfer card or an EBT card, as some of you may know, and it works exactly like a debit card. So an individual is able to go to a grocery store or a participating retailer that accepts SNAP dollars and purchase their groceries in that same way as a debit card. SNAP was previously known as food stamps, but then it was reformed into the Supplemental Nutrition Assistance Program in 2008. And this was really in efforts to fight off that stigma, as Megan had mentioned, of receiving federal nutrition assistance that a lot of individuals had faced before the program was reformed. It also, this reformation also reinstituted priorities to strengthen the program and also expand eligibility requirements to low-income individuals. And it also importantly integrated nutrition education as an element to an integral part of the program, and it is now known as SNAP ED or SNAP education. So this really, along with providing individuals with the power to purchase their own groceries at participating locations, they also now have the knowledge to make healthy food choices for themselves and their family. So in 2020, over 660,000 individuals in Virginia received SNAP with an average benefit amount of $112 per person. And out of those 600,000 individuals, 41% were children. So although this program is designed for low-income individuals and those facing food insecurity, many of them that are eligible for the program are not currently participating. As you can see in this figure here, only 78% of eligible individuals in Virginia received SNAP in 2019. And these reasons really can vary from stigma to a fear of applying, or really just being unaware that the program is available for these individuals. And as part of our efforts, the Federation to fight against food insecurity in Virginia over the next 5 years, I was put into this role to assist with increasing SNAP participation and increasing that rate for eligible individuals from 78% to 90% through outreach and marketing efforts. Can you go to the next slide? So the importance of SNAP. So SNAP is an integral approach to combating food insecurity, and it's because it can supplement a household's dietary needs. It enables families to purchase healthy groceries and also empowers them to access safe and nutritious food that will benefit themselves and their family. It also benefits the economy, farmers, processors, and other retailers across the state. SNAP is also a central government policy that is aimed at reducing food insecurity. It's the cornerstone of federal nutrition assistance. So because it's been shown to reduce food insecurity that affects many Virginians and Americans alike. It also benefits the economy. So for every dollar that's spent with SNAP benefits, it generates $1.79 in economic activity. SNAP also addresses all 4 pillars of food security so that families can reach that nutrition security and protect themselves against those chronic health conditions that Megan had mentioned. So a really great thing is it's available to a lot of participants with over 6,000 food retailers right now currently in Virginia that accept SNAP. Participants have the option to buy at large grocery store chains or to small convenience stores that are within their vicinity. It's also accessible and provides the participant to utilize their own money and their own funds to purchase groceries and gives them the power to make healthy choices. It's also a sustainable option for participants because it's an entitlement program for those that are eligible and struggling to meet their food budget. It also expands when poverty is increasing, and it can quickly respond to a household's financial needs during a time of uncertainty. Next slide. So there are various health outcomes that come from participating in the SNAP program. One of them being it improves dietary intake. Many studies have shown that SNAP participation does increase preschool children's intake of iron, zinc, niacin, thiamine, and vitamin A. It also has shown to lower rates of anemia and nutrition deficiency among children. And compared to low-income non-participants, those that are participating in the SNAP program consumed less sodium and saturated fat. SNAP also reduces chronic health conditions, as Megan mentioned. SNAP participation overall reduces the likelihood of food insecurity by 30%. So when an individual is facing food insecurity, it increases their chances of coping with chronic stress. Currently, the USDA's Economic Research Service documents that there's a very strong correlation between food insecurity and chronic health conditions among low-income working age adults. So this is why the risk of chronic conditions can significantly increase as the severity of food insecurity increases. Adults have also shown in households with very low food insecurity are 40% more likely to be diagnosed with a chronic disease compared to food secure adults. These chronic conditions, could include hypertension, coronary heart disease, asthma, diabetes, a lot of different examples, as I'm sure you're all aware of. SNAP also improves developmental growth for children. Participation in the program does result in better physical health for children, growth and development compared to eligible non-participants. It also, SNAP participation during maternal years improve birth outcomes such as birth weight for individuals that are pregnant. SNAP has also shown that early childhood participation also reduces the rate of metabolic syndrome among children. SNAP also increases preventative care for families. So those families that are facing high food insecurity really leads families to choose food over medicine sometimes. And a lot of them may postpone medical care or stop focusing on special medical diets that are extremely important in maintaining their current condition. SNAP is and since SNAP provides families with funds to spend on groceries, it frees up their resources so that they can be used for medical care or other associated costs that benefit their situation currently. And that's why adults that are participating in the SNAP program incur 25% less in medical care costs than non-participants. So I want to give a quick overview of what the Federation is doing and how we're approaching our statewide outreach strategy. So we've begun by developing SNAP marketing materials with specific messaging catered to specific populations in Virginia with low SNAP participation rates. And these marketing materials are really designed to provide our local and state organizations with resources so that they can connect community members facing hunger with information about SNAP. And along with the help of our member food banks and their food pantry network and other state partners across the state, our marketing materials are distributed to the community through their staff and volunteers, where they could also provide pre-screening for eligibility and also assist with SNAP applications. So once these marketing materials reach the community, they're able to learn more about SNAP and hopefully get connected to a local food bank assister or a state partner so that they could apply for SNAP if they would like to continue on and proceed with an application. The Federation has worked along with our member food banks and our statewide partners so that we could include healthcare partners and other food pantries so that we can assist with more applications. So as I mentioned, our healthcare partners play a really vital role in connecting food insecure patients to nutrition assistance through food security screenings. So the following diagram really shows how to identify and address food security at a healthcare site. You can use tools such as the Hunger Vital Sign that has been widely used in medical and community-based settings across the country, where you can screen community members for food insecurity and then refer them either to the Federation and our member food banks and pantries or to immediate food assistance through food distribution programs or connecting them to other local food programs in your local area. Next slide, please. So what can you do to connect neighbors to SNAP? And neighbors, I also mean patients, along with resources and support provided by the Federation and all of our materials, your clinic does have the opportunity to connect your patients to food assistance and help them reach that nutrition security. It could be through one of the following avenues, such as training your staff about SNAP. Currently, the Federation is holding some virtual SNAP training events to educate those that are interested in the program and learning more about how to assist neighbors with SNAP applications. So a really useful tool to implement into your clinic. You could also, along with the materials that are provided by the Federation, display information or posters in waiting areas of your clinic, or provide handouts to families about SNAP during appointments and beginning that conversation. Another important part is just sharing information on your clinic's website or your social media so that patients can easily read and access information about the program and screen for their eligibility. I also wanted to finish here with some additional resources that may be really useful in learning more about the SNAP program. I'm including here the SNAP outreach flyers that I had mentioned. These were the flyers that we had developed with very targeted messaging for those populations with low SNAP participation rates in Virginia. They're available in English and Spanish. If you click the link or that title right there, it'll send you to a digital copy of these flyers where you can print them out. And there's also, it's a PDF version. I'm also including here the SNAP Outreach Toolkit. I really encourage you all to use this resource guide that provides an overview of SNAP and program requirements and details and other eligibility details and more. So please feel free to use that. It also has a lot of additional information in there, and we're regularly updating it with most up-to-date information on the SNAP program. I'm also including here the SNAP training registration form, which is those the training that I had mentioned earlier. There are virtual training sessions that are held by the Federation, and it covers two topics: SNAP program basics and SNAP application assistance, which goes more in depth of how to fill out an application for a community member and how to dedicate some time to fill out the application to its entirety. And then Megan already showed you all the Federation's Find Assistance page, but it's our neighbor-facing webpage to connect those interested in applying for SNAP and getting connected to a local application assister. These are also posted on the call to action on our outreach flyers so that neighbors are able to reach out to the Federation if they're ever interested in looking for an application assister. Well, I'd like to sincerely, I sincerely appreciate all of your attention and your interest in learning more about the importance of SNAP. And I really welcome you all to contact me if you have any questions about the program or how to help your neighbors even further. So thank you so much. And Megan, I'll pass it to you.
Thank you so much, Nicole. Oh, sorry, Megan, did you have a little bit more?
Nope. Are we taking questions at the end?
Let's do them all at the end. Yeah.
Great.
And Nicole, are you able to post the links to those resources in the chat while we continue?
Yeah, of course.
Okay, thank you. I think that would be helpful. In the meantime, I'd like to introduce our next speaker, another Megan Nason, who's a registered dietitian currently working as the Virginia WIC program manager. As the program manager, she oversees the daily operations of the Women, Infants, and Children program within the Commonwealth and supervises the state WIC office staff. She received her undergrad degree from Virginia Tech in Human Nutrition, Foods, and Exercise after receiving her Bachelor of Science degree. She went on to obtain her Master of Science degree in Nutrition and Physical Activity at James Madison University, where she also completed her dietetic internship. Following graduate school, Megan began her nutrition career working as an RD at a nursing home and skilled nursing facility in the greater Richmond area. In 2012, she shifted her focus from clinical nutrition to public health, working as a nutrition liaison for the state WIC office. While working there, she transitioned into managing the dietetic internship program. In 2017, graduated from the emerging New Leaders in Maternal and Child Health Nutrition Training Institute. In 2019, she moved into the role of program manager, where she continues today. Megan lives in Ladysmith, Virginia with her husband and 2 daughters. Outside of work, she enjoys spending time with her family, cooking, running, and cheering on the Hokies. All right, and with that, go ahead.
Thank you for that. Can you hear me okay? I'm having a little connectivity issues.
We can hear you and we see your slides.
Okay, perfect. Well, thank you for that. Yes, I am another Megan working in similar field. I am the program manager for the Virginia WIC program. First, I want to say thank you to Megan and Nicole. Those were really great presentations, very informative and beautiful slides that you had. But thank you all for having me here today. I want to spend some time just kind of going over the, an overview of what our program is, kind of where we're at now on the tail end of pandemic and where we're moving forward to. So with that, I'm just going to start with some basics about the WIC program. WIC is a supplemental nutrition program for women, infants, and children. We are a federal program that is administered by state agencies. So nationally, WIC is administered by 89 different state agencies through the 50 state health departments, 33 tribal organizations, DC, and then there are also 5 territories. We were established in 1972 as a pilot program, and it became permanent in 1974. So coming up right on that 50-year anniversary. So it'll be big celebrations next year for the 50-year anniversary of WIC. Some interesting information about WIC is that we serve about half of all infants born in the United States. And there's been numerous studies similar to some of the SNAP studies that Nicole spoke of, conducted by USDA and then also some non-government entities that have proven that WIC is one of the nation's most successful and cost-effective nutrition intervention programs. And since 1974 has earned that reputation of being one of the most successful federally funded nutrition programs in the United States. So the overall goal of the program is to safeguard the health of low-income women, infants, and children up to the age of 5 who are at nutrition risk by providing nutritious foods to supplement the diets, information on healthy eating, and referrals to healthcare organizations. The benefits of the program, many know about the supplemental foods side of it. We know the reputation of getting formula from WIC is probably one that most people do know of, but WIC does provide our participants with nutrition education and counseling, breastfeeding support and promotion, referrals, like I said, to health, welfare, and social services, as well as those supplemental foods that do include formula. But just important to note that that is not the only benefit of the WIC program. Okay, so again, some of those studies that have been done, I'm not going to spend too much time going into the details of them, but there have been some that have proven, that the WIC program has been playing an important role in improving birth outcomes and containing healthcare costs. There's also been studies that have found WIC to have positive effect on a child's diet and diet-related outcomes, including higher means intake of iron, vitamin C, thiamine, niacin, and vitamin B6, without any increase in food energy intake, indicating an increase in that nutrient density of the diet. Additionally, WIC promotes breastfeeding as the optimal method of infant feeding. And studies have shown that WIC participants who reported having received advice on breastfeeding their babies from the WIC clinic were more likely to breastfeed than other WIC participants or eligible non-participants. And additionally, there have been studies that found significant improved rates of child immunization and having a regular source of medical care associated with WIC participation. And also improved vocabulary scores for children of mothers who participated in WIC prenatally, and significantly improved memory for numbers of children enrolled in WIC after the first year of life. So jumping on to how someone may be eligible for WIC, there are 4 different aspects to eligibility for the program. First being categorical. So the WIC program is designed to serve categories of women, infants, and children, as the name does indicate. And within that, women are eligible when they are pregnant, during pregnancy, and then up to 6 weeks after birth of an infant or the end of the pregnancy. Postpartum, up to 6 months after the birth of the infant or the end of pregnancy, or breastfeeding up to the infant's first birthday. Residential requirements for the program are that applicants must live in that for how long they have to be a resident in that locality to be residentially eligible. Oh, great. The income requirement is that applicants must have income at or below an income level or standard set by the state agency up to 185% of the federal poverty level, which is what it is in Virginia. And we do update those each year based on the poverty level and have those numbers available on our webpage. There's also a way to be income eligible through something that we call adjunct eligibility. And this is for participants that are determined to be income eligible based on their participation in other programs. So for example, participants in the SNAP program could be adjunctively eligible for the WIC program. or income eligible for the WIC program. Same with Medicaid and TANF participants. And then the last aspect for eligibility for the WIC program is the nutrition risk requirement. So applicants must be seen by a healthcare professional at the WIC clinics that can assess this, meaning, if they have some type of medical-based or dietary-based incomes or conditions, medically based conditions. And it can include a variety of things such as anemia, underweight, poor pregnancy outcomes, and then some dietary examples are poor diet. So we do take some height and weight measurements and hematological and do a full nutrition assessment of the participants during their WIC appointment. So in Virginia, the WIC program is within all 35 health districts, which is made up of over 200 clinics. Our state WIC office is located in Richmond, Virginia at the Virginia Department of Health, which we do support our local agency clinics, providing guidance and oversight related to ensuring compliance, and also providing those federal funds to be able to run the program locally. Our current participation is we're over 120,000 participants per month. And just for a little perspective, February of 2020, so right before COVID, our participation was around 108,000 participants per month. So we've seen a significant increase in participation over the last 3 years. So I just pulled off a couple images. This is not all of the food packages, but just to kind of give a visual of what the different food packages look like. So the WIC food packages provide supplemental foods designed to meet the needs of our low-income pregnant, breastfeeding, postpartum women, and infants and children up to 5 years of age who are at nutritional risk. Those food packages and nutrition education are the chief means by which WIC affects the dietary quality of our participants. So these food packages are based on federal requirements through which category that they are in and also their nutritional needs. So for example, you can see here, a fully formula fed infant would be only receiving formula during the 4 to 5 month package. And then a breastfeeding woman would receive a larger food package compared with a non-breastfeeding postpartum mom, just based on the increased nutritional needs for a breastfeeding woman. So each month participants have their benefits loaded onto an EWIC card used to purchase those approved foods at our authorized vendors. Way back in the day, you probably heard about WIC checks, which used to have the same foods written onto checks, which had to be fully spent at that vendor at that time. So the beauty of EWIC, which we've had for probably about 10 years now, is that the moms can go to the stores and purchase as they need throughout the month. And instead of having to get all 5 containers of milk at one time on one check and worrying about one spoiling before they could use it, now they can use the EWIC cards to purchase the benefits throughout the month. So to help with some assistance for the shopping experience, participants do receive our food list, which shows what can be purchased with their benefits. Just to give an idea of some of the different items that are eligible in our program, things like breakfast cereals, cheese, eggs, fruits and vegetables, juice, infant foods, peanut butter, milk, whole grains, and yogurt. And USDA recently proposed some new science-based revisions to the food packages. So we're really anxious to see what some of those look like to ensure, the latest nutrition science is supporting that healthy eating. I know we're coming up on a little bit of time, so I will not go through all of the details of what those proposed food packages are, but just to highlight a few, they're looking to expand some of the whole grain options to accommodate individual and cultural preferences, taking a look at the amount of juice that's recommended for children, providing some more non-dairy substitution options, and then including canned fish into more food packages than just the breastfeeding mothers package. So we're excited for those. The comment period was open to the public through February. So that has finished, and we are awaiting the next steps of what those new food packages may look like. All right, as I mentioned earlier, WIC also does provide formula to partially breastfed and fully formula-fed infants. Each WIC state agency has a contract with one of the 3 major manufacturers to provide specific formula to WIC infants. About half the state agencies do have contracts with Abbott Laboratories, with Virginia being one of those. So we do provide the Similac brand products. And then for participants with medical or nutritional needs, they can receive specialty formulas, which I just wanted to take a screenshot of what our formulary is that can be viewed on our webpage as far as what those products are that are available for participants with special medical needs and a prescription. All right, so since 2020, we have been providing our program through remote services under the COVID-19 waivers. We are coming up on wrapping that up, but we did receive some waivers that allowed us to operate remotely. With the most widely used waiver being that physical presence waiver, which removed the requirement for the participants to be physically present during their appointment. We do know that these are ending as of May 11th of this year with a 90-day phase back in period. So we anticipate returning to in-person services in August of this year. Major issue that came up this year that I'm sure many of you are aware of was the formula recall that happened last year in February of 2022. Like I said, our contract is with Abbott, so the Abbott recall was highly impactful. We were able to, again, utilize some different waivers to offer different formulas during that period, so that participants could redeem different brand products with whatever they could find in the stores while those shelves were very bare. We have come somewhat out of that beginning this month in March and did the waivers for those other products. So the stock is looking healthy at this point, but we have been keeping an eye on redemptions to ensure that those products are still available for participants as they need them. And then the federal government did increase what is called our cash value benefit, many times referred to as a CVB. Previously, children received $9 a month and women received $11. So you can see the new amounts listed here based on participant categories significantly higher. So this is what participants can use to purchase fruits and vegetables each month. And redemption has been really great on that. So it's great to see that the participants are utilizing that to increase the fruit and vegetable consumption. All right, let me get an eye on time. All right. Just really quickly here, I wanted to touch on WIC's special relationship that we have with Medicaid. They are one of those programs that is adjunctively eligible for our WIC program. We do have a MIS interface with their computer system that allows us to check for participation in Medicaid. Additionally, we have a special contract or unique relationship with them related to formula coverage. So outside of normal federal requirements and state code, Medicaid and the WIC program, there's an agreement intended to improve the use of government state resources and more effective service delivery. Under that agreement, Medicaid reimburses the WIC program for the cost of all those specialty formulas and medical foods for infants and children that are enrolled in Medicaid. So these claims are paid for monthly based on that agreement that we have, which is really great because we're able to offer then formulas to those participants that need them, have a medical need for them. And this also covers any difference that is above the allowed amount for the WIC program. We can offer that overage and then Medicaid will reimburse for that, which allows for the participants to not have to go and seek out the additional formula needed at another location. They can get it all right onto their benefits or shipped to them from a warehouse. I'm going to skip over this slide because I do know we have some questions that we want to get to. And I just want to kind of touch on our relationship with the healthcare providers who are a key partner with the WIC program and for our participants. We have many resources available on our webpage, on the healthcare provider page, which I again put a screenshot on here, but that does include where we put most of our updates that are relevant for our healthcare providers, our prescription form for those specialty formulas, a medical referral form, which I will touch on in 1 second. And also located here is approved formula list, a fact sheet, our contact information, and an FAQ section that's very, very helpful. As we are planning our reopening and phasing back in to the clinics, it's going to be important to maintain that strong partnership with the providers to help those clinics reopen. With the potential for kind of a hybrid approach to the reopening of the clinics, we'll be able to accept some measurements from providers for anthropometric and hematological measurements to minimize that clinic contact, shorten clinic appointments, and the time needed to be in person. So that medical referral form is going to be highly valuable for the transition process. This is just a screenshot of our prescription form. Not going to get into the details of that, but did want to point out there was a new form as of March 1st. Looks very similar to our previous form, with the difference being that now we do need to collect NPI numbers from the prescribing providers, which helps submit those claims to Medicaid. And lastly, here are the links to some of our web pages that you might want to look at for some more information. With our main page, we have our participant portal as well that participants or applicants can go to and see if they are eligible. And if they are eligible, they can apply there. And then a clinic in their locality will reach back out to them to set up their appointment. Eventually, we want to add that appointment feature into that portal where they can just go ahead and schedule the appointment all during one visit to that to the web page. And on that, just a long-term future goal of ours is to create a healthcare provider portal where we can receive measurements and the prescription forms to kind of minimize that paper trail and just be able to submit them straight to the clinic to ease that process up. And then our contact information, I went ahead and put my contact information on here. We do have a state office formula contact for anybody that has questions about product allowability, diagnosis, anything like that, that you might want a direct answer to based on the specific scenario. All right, I think I kept us in. I know there's like 5 minutes left, so hopefully there's time for questions, but thank you, everybody. Thank you for having me.
Thanks so much, Megan. Before we open it up for questions, I did just want to invite Dr. Powell to give a quick couple-minute talk on Bridge to Resources for those that may not be familiar with that resource that we have at our disposal, and then we'll open up for questions.
Okay, great. Thanks, everybody. Yeah, I'm only going to talk for like a second. I just want to let everybody know I'm Dr. Powell from, I'm the current president of the Virginia chapter of the AAP. And I just want to let everybody know about a resource our chapter provides for social needs screening for food insecurity. So it's called Bridge to Resources Virginia. It's free. I know a lot of our offices may have social workers, a lot of our offices don't. We may also use Unite Us. This is just another option for people that if you don't have either Unite Us or a social worker, again, it's free to you and it's free to our families. It can be for patients, neighbors, community centers, anybody. It's anonymous searching for local food pantries, food banks, SNAP, WIC, all those sites have been added throughout the state. So all you have to do is go to our site, type in the zip code and you'll see a listing of all these free or low cost services. Know that it is updated and everything on there, there's eligibility and all of that information there. You can print it out lists for families. You can give them a postcard so they can search on their own. Some families do want to search anonymously. Some families want to search repetitively throughout the year. So this is kind of nice for that. And it also comes in over 100 different languages. Just to show you, the QR code is there on the left. And what the screen will look like is on the bottom where you just type in your zip code. There is a little pop-up for Medicaid unwinding resources. Here's some postcards that you can request for your office from us. Just email me at Virginia AAP and I can get you these postcards. We also have magnets and little stickers with QR codes for our badges. And then here's example, last slide of like what our reports look like. We can, through this resource, we can look and see what the needs are in various parts of the state. And as you can see, looking for food is the top search, not surprising. And then we can also see what areas are using this. And we're going to do a project. We have a grant to look in the western part of the state and see what the needs are in the west, southwest, and try to do some outreach out there. So stay tuned for that and let us know if you live out there and you want to be part of that project. Okay, and then I'm turning it over for questions. And one question I need, everybody's asked me to ask, is just juice for WIC. Can you, Megan, explain why juice is included in WIC? I'm sure you've gotten that question a million times.
Yes, and that is one of the come in, it's fine. That is one of the proposed changes to the new food packages, is the decreasing of that, because yes, although there is some minor vitamin or minerals that you may be able to get, the negative side of juice is well known and probably not as necessary as previously thought. So I know that a lot of WIC programs are excited to see, hopeful that change in the new packages, knowing that we have that increase in the fruit and vegetable voucher, so being able to utilize the whole foods instead of the juice side of it.
And thank you, Nicole, for putting all those resources in the chat. It looks like the next question is also from Dr. Powell. Now that the AAP is recommending breastfeeding until age 2, looks like this question is also for you, Megan Nason. Will WIC change to cover breastfeeding mothers from age 1 to 2?
Yes, we actually had a call not too long ago once the recommendation changed, and that was a high topic from many different state agencies for USDA. So I know that they are looking into that also, with potentially the hope to extend to age 6 instead of age 5 for children as well, because of knowing, many times the school system does pick up at age 5, but not always. So if we could also extend for children out to age 6, I know that the breastfeeding for the 2 years and children up to age 6 is, fingers crossed, on the horizon.
Awesome, thank you. Next question might actually be for Kelly, to keep me straight. Obviously, we are recording this session. I assume we'll be able to distribute it to people on the call and also just VA-AAP members in general.
Yes, that's correct. We will, every registrant will get a copy of the recording of the presentations.
Great. Any other questions in the chat, or feel free to chime in if that's easier. And if not, I have a couple other, oh, go ahead, Dr. Powell.
Are you sure? Okay, I don't want to monopolize, but just so I have it correctly, with the ending of the PHE remote service, people will have to go in person, correct? To WIC now, we can't do it remotely starting in May. Is that correct?
So starting in May will be, I'm just going to say, like a soft opening. So the waivers will still maintain in place from that May to August, that 90-day period.
Okay.
So that's when our clinics will be kind of phasing back in and working through the details of how it's going to look. There will be some changes to kind of how clinics used to run, knowing that we can keep portions of the appointment remote even after the waivers expire. But there will be, an aspect of that physical presence, either with measurements or bringing income information in. So there will be an aspect of physical presence. Yes.
Thanks.
I do have a couple of quick announcements before we hop off. Just that, thank you to our 3 speakers. I think this was really wonderful, and we all really appreciate you taking the time to speak with us today. And to announce that our next Lunch and Learn, while very loosely formed, is going to focus on how to set up food resources and food access in clinics, in outpatient clinics, including food pantries and access to fresh food. So that is coming on the horizon. The Food Insecurity Committee is also going to start drafting up healthy recipes that have SNAP and WIC eligible foods on them, that include, foods that mirror my plate, and hoping to post those on our Facebook page. So look out for that. And then if anyone is interested in joining, since we are still a new committee, please reach out to me, Dr. Powell or Kelly, and let us know. We'd love to have more people. But thank you so much, and meeting adjourned.